This program is brought to you by Emory University.
All right, we got a pretty good crowd here already, so we'll go ahead and get going. Good morning, everybody. Welcome to Friday Morning Fellows Conference. Our speaker this morning is Dr. Matthew J. Brown, one of our first-year fellows, not to be confused with Dr. Matthew T. Brown, who's one of our second-year fellows. Matthew is originally from Ohio, went to Ohio State University, undergrad, Wright State for medical school. Did his residency here at Emory, was the chief resident, one of the chief residents down at Grady last year, and is going to talk about, I'm not sure what, based on the title, seemingly chest pain. So we'll see what he's going to talk about. Dr. Brown.
Thank you. Yes, trying to keep the audience in suspense to get started. So this is, we're going to be talking about angina to some extent. We'll quickly get to the topic here soon. But thank you for having me. I have no disclosures, as most fellows don't. So here's the case. So it's a 51-year-old male. He has a past medical history of hypertension, HFrEF with an EF of 15% from about a year ago. Non-ischemic. He had a coronary CTA in May of a year ago, which did not show any coronary artery disease. He unfortunately suffers from polysubstance use, and he has some mood disorders. And he came into the hospital with 2 to 3 weeks of worsening intermittent chest pain. He says it lasts about 5 to 10 minutes. It's associated with dyspnea. And yesterday, his symptoms became acutely worse, so bad that it kind of brought him to his knees shortly after smoking a cigarette and while drinking some alcohol. His home meds, a little unusual on the right, but adherence to these is not really clear and suspected to be not very good. Okay, so this is his EKG when he came in on the left. That's the new one. Note that it's unclear if he had chest pain at the time of this EKG. And for comparison, the one from a little over a week ago is on the bottom right. So looking at it, you probably think it looks kind of normal. And for the most part, that is correct. There's no significant marked abnormalities. He does have some early repole and some electrical signs of LVH, or borderline LVH, but that's about it. Okay, so his physical exam. His vitals, his temp is normal, blood pressure is high, heart rate is borderline tachycardic, he's saturating well on room air, and his BMI is 29. Nothing really notable, except that he is not volume up on exam. His JVP was at the base of his neck. He didn't have any pedal edema or edema in his lower extremities. His lungs were clear to auscultation. Here are his labs. Also, not too bad in terms of chemistry and hematological labs. His potassium was notably normal. His MAG was notably normal. His UDS did show positive for marijuana, but negative for other illicit substances. And he did have some alcohol in his system. His BNP was 201. His troponin was, and this is the non-sensitive troponin, was 0.27. And then it kind of leveled off over the next several hours and throughout the morning. So what is the working diagnosis? Well, it's not really clear. He certainly doesn't have any changes on his EKG. He's no longer having chest pain this morning, but we need some kind of further workup. So we got a repeat coronary CTA, and it showed a lot more atherosclerosis than compared to a year ago, which is interesting. So he had some, long atherosclerotic plaque in his RCA, and he had some possible stenoses in his LAD and his left circumflex, all pretty significant. So now he has some obstructive coronary disease on imaging. So to the cath lab he goes. This is, we're going to focus on the RCA because that's where this case goes to in the talking points. We did not intervene or do, and there's nothing really significant on the left coronary. So, okay, so here's the shot of the RCA. As you can see, it looks pretty good. there is, oh, where's my notes? Okay, so there is a little bit of atherosclerosis you can see in kind of the mid segment. There's probably about a 50% stenosis there. Everything else, and a little bit more distally, he probably has some disease as well, right before it bifurcates there at the distal part. So let's go to the next shot, though. Can't tell anything in one shot. So as you can see, from the first shot that we couldn't tell is that the first part of his RCA is a little tortuous, which is notable, as we'll see in the next shot. Okay, so here's just a shot to show you the engagement of the FFR RFR wire to evaluate that lesion in his RCA. And as you can tell, I just want you to focus in, it still all looks about the same as the prior shot, though there is significantly less contrast with this one. Okay, so upon administration of adenosine, and probably just happened to be shortly after that administration, he developed a very tight, greater than 90% stenosis in the proximal portion, and then some various regions of focal stenosis throughout the rest of the right coronary artery. And this was associated with angina, and he did have some EKG changes in the lab. And he said that this was similar to the pain that he had been experiencing when he was at home. So just to show you that it did resolve, here's the nitro bolus that he got after noticing that. And you can still see there's still some areas of focal stenosis, especially a very small part at the top, but it definitely did improve with nitroglycerin. So here's the FFR, because the wire was already in there, and this is what it measured. So the proximal portion pressure and the distal pressure, just for people who maybe haven't been to cath lab, is kind of noted. And then when you put the distal over the proximal pressure, that's how you kind of get the FFR during maximal flow or hyperemia, which is the reason for the adenosine bolus. And anything less than 0.75 or 0.8, depending on the operator, can be considered significant. And so this had 0.33, which is quite robust. However, in this particular case, you can't really interpret the FFR because the working diagnosis is that he likely had a vasospastic event from induction or agitation of the wire itself. So the adenosine just happened to be injected during that time, but that's not the culprit in this case. It's just the wire. So he clearly has sensitive vasospastic reactivity in his arteries, which is abnormal. And so if we look at, he did have some OCT, or optical coherence tomography. On the right is the OCT from this patient. And on the left is just some normal and abnormal baseline pictures for you to kind of get a sense of what we're looking at if you're not very familiar with OCT. So just to quickly orient you, so you can see the intima media and adventitia. It looks like very perfect circles on a healthy coronary artery. And then as you get disease, you can kind of see down below what different plaques and calcification can look like. So I'm just going to kind of play his OCT as we kind of talk about it further. So as you can see, kind of the bottom part is the overall tomographical picture of his entire coronary as we're kind of pulling out, becoming more and more proximal. And again, the spasmatic part was in the more proximal segment. The shadow that you see in there is the wire, the guide wire that you're pulling the light source over as it comes back. So as you can see with the gray haziness there, or not gray, I guess, but the haziness rather, he definitely has some plaque, probably some fibrous plaque and some lipophilic regions, not as much calcium. There's not any super bright areas. It's mostly just a bunch of haze. So definitely has some signs of atherosclerosis, but nothing. You may see some stuff in the vessel there that's just blood. He does not have any thrombi or anything that would be consistent with an ACS type of event. Okay. So that gets into this broader topic of Minoca, which is kind of the focus of today's talk. But we're going to specifically be getting to one aspect of Minoca here shortly, which is based on this patient's presentation. So Minoca is myocardial infarction without any signs of coronary artery disease, and that means less than 50% atherosclerosis is considered non-significant coronary artery disease and required for the diagnosis of Minoca. So it's thought to be that this is about 10% of cases that come in with MI. And there's a wide range of data, but it's possibly between 45 and upwards of 80%, which is probably too high, but could be vasospasm induced to some extent. So diagnostic criteria include has to be an infarction or signs of infarction, has to be non-obstructive, as I said, and has to be no stenosis greater than 50%. The asterisk is to say that, that is somewhat subjective. So you kind of have to base it on the operators and team's assessment. And then no specific alternative diagnosis like sepsis or myocarditis or PE. So this is kind of a schema of how to work through Minoca. So if you have obstructive coronary artery disease, then you're already done, and you can stop before you even get in here. If you have an alternative diagnosis, you're also already done, and you can stop going down this algorithm. But basically, it's the yellow zones that are challenging for most diagnostic studies. And so what it recommends is that a couple things here is that if you don't see obstructive coronary artery disease, but you still have signs of infarction, again, the diagnosis of Minoca, the next step is probably to get a CMR. Now you're going to be in the cath lab though to make this diagnosis. So the true next step is probably doing IVUS and OCT to kind of get a better appreciation of the coronaries. And that'll help you delineate things like SCAD or thrombi, or spasm, as in our patient's case. But there is a strong recommendation from this paper and from others to proceed with a cardiac MRI afterwards, and that can kind of help delineate the other thing, or the other diagnoses rather. And so basically what this shows is that cardiac MRI will diagnose troponin elevation in upwards of 75% of the time. So whether it's something like Takotsubo's, myocarditis, or some other type, or just confirmation of actual infarct, the cardiac MRI is going to be your best answer. And then if it's not that, then you can work down other potential etiologies. Okay, so here are some specific causes, and we'll kind of get through some of these very briefly in the next few slides. So plaque disruption, and again, this is different than, I guess sometimes we think of plaque disruption as like the etiology of STEMI, but sometimes you can have Minoca because they may not have coronary artery disease, but they had this unhealthy plaque, and it just happened to kind of rupture or erode. So these are patients that just have unhealthy vasculature, and they couldn't contain the less than 50% stenosis, essentially. And so the frequency of this is unknown. It's been reported that this plaque disruption with Minoca does, again, have some evidence of atherosclerosis typically. It usually just doesn't exist without it. And then this is where the IVUS and OCT is going to be really important for helping to rule out that etiology. So here are just some examples on IVUS and OCT. So you can see from the left, there's a nice picture of what a fibrous cap and erosion would look like there. And then there's an ulcer in the center and a loose thrombus in the vessel on the right. Okay, so next, another type of Minoca is potentially an embolic source. And again, it may seem confusing, but just remember what the absolute, like the definition of what Minoca is. So this usually, though, involves more sometimes the microcirculation or the smaller vessels, not the true, quote, epicardial vessels, which we angiogram in the cath lab, because it ultimately depends on the size of the embolism in the thrombus. And here's we all know the multitude of different things that can kind of cause these. Here's a few examples, notable ones on the screen. And then there's SCAD, and there's whole talks on SCAD. So we're not going to deep dive on this, though very interesting in its own accord. It is another subclassification of Minoca, or can be at least. And then there's microvascular dysfunction. Again, another kind of emerging topic, which we're not going to get into in this talk. But this is the vast microvasculature that we have, again, outside of the epicardial coronary arteries, that can be dysfunctional and actually cause infarction if you have severe enough disease or dysfunction. Okay, so what we're going to focus on is more epicardial vasospastic angina. Now, this is an old diagnosis in cardiology terms. Basically, we all know Prinzmetal. It's also called Prinzmetal's angina, and he first noted this in the literature dating back to 1959. So it's been around for a while. Now, at that time, they actually only kind of first evaluated it in patients with coronary artery disease, so the definition has kind of changed over time. But the pathophysiology is somewhat similar. So how do we define vasospastic angina specifically? So it's in 2014, before 2014, there was no real consensus as to how should we as a group of cardiologists define this disease. But now we kind of have these main buckets of definition. So you have to have clinical manifestations, documentation of MI, and demonstration of spasms. And so specifically, what does that mean? So for clinical manifestations, that means that you have nitrate responsive angina. So during an episode with at least one of the following, so that's kind of self-explanatory from there. And there's different ways to kind of suppress that as well. Documentation of MI. So you see ECG changes consistent with myocardial infarction. And then demonstration of spasm. And this is the definition is greater than 90% constriction. And that's been in a lot of, that definition has been in a lot of the Japanese and South Pacific definition of coronary spasm. Some of the US studies, though, have used greater than 75%. So at least greater than 75%, but typically greater than 90%. So risk factors, there are several. There's anxiety, and there's some interesting studies that it's pretty significant versus controls. So I think sometimes that's a thing that we can overlook as cardiologists, more focused on risk factors that we can reverse. But a lot of times, getting patients in with mental health and taking care of that can improve their cardiac health. And there's the obvious ones like smoking and alcohol intake, and even more obvious ones like cocaine and cannabis and amphetamines. And then there's also some notable medications that patients may be on from other subspecialists like 5,4-uracil for some type of chemotherapy treatment, or triptans, or even serotonin itself, but that's more based on in vitro studies. And less in actual vivo, but triptans can certainly be an inciting factor that patients can be on for their migraines. So how do we diagnose this? So we'll get into that in a second. But who do we diagnose this in, or how do we move forward with testing? Well, the European Society of Cardiology has these recommendations. So they have class 1 indication for provocation testing. If you notice ACS event without coronary artery disease, unexplained cardiac arrest or syncope with preceding chest pain, or recurrent angina despite successful PCI. The US indications aren't quite as strong. We only have a 2A recommendation for this testing, mostly because we don't have a lot of studies in the US that kind of support the use of this, but that's quickly changing. So I want to get into a little bit about the pathophysiology of endothelial dysfunction, rather. So basically, you can, if we start off at the top box is your endothelial lining, the smooth muscle is below. And it's a kind of a communication between the two. Those receptors at the top can induce vasodilation. So as you can see, ACH is the focus here because that's what we use for provocation testing. And it works in a calcium-dependent manner to release nitrous oxide, which gets diffused across into the smooth muscle through a GCMP pathway and causes relaxation of the smooth muscle. Shear stress can also do this in a calcium dependent way, so that it knows when it's under pressure more, the endothelium or the smooth muscle rather, will relax. So diagnostic testing, there's 2 main medications that are used, but only acetylcholine is used in the US. So just, I have the ergonovine here just for kind of historical context, and, things change. So it's possible in the future that the ergonovine moves to the US. And we'll talk about the differences between the two in a second. But basically how the test is performed is it's usually performed in the morning. And you're supposed to discontinue all of the medications that could kind of counteract your assessment of vasospastic angina, and caffeine 2 days before the study. The reason for the early morning is because there's been studies that in early morning and late at night, vasospasms can be worse based on the sympathetic diurnal activity in our bodies. So you have the best likelihood of having a positive test in the morning. So for acetylcholine testing, just the fine details of this are probably less important for this talk, but just wanted to kind of give you some baseline that there is a different dose based on if you're in the RCA or the LCA. Those are max doses that we typically don't reach in the cath lab, and it's somewhat operator dependent. And the one thing that should be noted is that, for instance, in the LCA, the max dose is 200 micrograms. And the one thing that I didn't note back here on the endothelial physiology is that specifically for acetylcholine, it is a vasodilator, but it's in a dose-dependent manner. And so if you, in a healthy tissue, acetylcholine will dilate and cause relaxation. But even in healthy tissue, if you give enough, the other, there's different types of muscarinic receptors, and the ones that start getting saturated at higher doses will actually cause vasoconstriction. So it is kind of dose dependent. You have to be careful how much you give, or you're going to have a false positive test. We don't have a lot of false positive tests, though technically it may be hard to prove that, but the doses are considered low enough to not induce that. So the differences between these two are, again, not really studied in the US, so kind of take it with a grain of salt. But acetylcholine is used much more worldwide. Ergonovine is mostly in the South Pacific. The acetylcholine is more rapidly reversible, but has a higher propensity for arrhythmias, though small overall. And it probably is better at inducing spasm in females, and less so in younger patients compared to ergonovine. So what does it look like when you're in the cath lab testing? Well, here are some examples. So our patient had a focal vasospastic event, as you can kind of see in the left. In the center there, well, actually they actually ended up having segmental, but the focal was the most obvious. And then there's diffuse, which you can see on the right. In the bottom are pictures after nitroglycerin was given for reversal. So that'll kind of help give you more of a baseline. Okay, so diagnostic testing. So this was the first study that was really done in the US. This was done in a mostly Caucasian population, though. And this was to kind of look at how does acetylcholine testing provoke vasospasm in patients with non-obstructive coronary artery disease, and also what type of epicardial spasm is typically induced. So as you can see, about a third had epicardial. There were some microvascular in about a quarter, and then the rest were kind of inconclusive or uneventful. Most of them were diffuse, like we kind of can see in the in box E, and only a very small percent were focal. And classically, with variant angina, focal vasoreactivity is thought to be what we think of when we think of that specific diagnosis, but it's much more broad than those previous thoughts. Okay, so I think I've talked with a couple various attendings, and I think based on comfort level, there's a lot of concern about doing these testings, because when they first came out, there was a lot of risks, and then the question is, well, what's the benefit if there's risk, and is there enough benefit to even outweigh that? So this is a very recent meta-analysis that looked at what is the actual complication rate in these patients, and what are those complications, and it's very, very small. It's still recommended to be done at a center that is familiar with these tests. Obviously, you don't want someone doing it that isn't, but you need to have like the resources, God forbid, one of the adverse events does happen. But the complication rate is only 0.5%, so extremely small, and 0% mortality. And then a lot of that is usually done in the inpatient setting. There has been a specific outpatient study, like can you safely send these patients home afterwards? And only about 0.8 required hospitalization post-procedure. So again, this is a very safe study. In the right population, we should probably be evaluating further, but we'll talk about what that right population is later. But I just want to kind of relax your guys' tone to know that this is a safe study. What are the adverse events when they do occur? Hypotension, kind of things are going to be associated with parasympathetic activity. So hypotension, bradycardia, and then rarely paroxysmal AFib, which was more common when studying the RCA over the LCA. But 100% of people that did get that returned to normal sinus rhythm by 2 days. So there's a little concern there. Okay, so why does it matter? So half of adequately treated patients experience angina. And so we need to know, like, despite like adequate PCI, we need to, these patients may have morbidity that we can reverse for them if we get them on the right medications. And sometimes having a definitive diagnosis can kind of help them with that. Now, again, this is only one piece of that kind of puzzle. There's also like microvascular dysfunction, again, as I kind of mentioned earlier, which can also be delineated out at the same time in the cath lab, but that's kind of beyond the scope of this talk. But just know that it's a very broad picture of what can cause angina outside of obstructive coronary artery disease. We want to lower the mortality rate. Mortality still exists for these patients who have vasospastic events. It's worse with advanced age. Obviously, if you have multivessel or diffuse spasms, And there is a chance of out of hospital cardiac arrest if it's severe enough. So what is the treatment for these patients once we have a diagnosis? One of the treatments, and really the treatment, the mainstay, is calcium channel blockers. You really often need high doses of these to help counteract the vasospastic events. So this is your first, second, and third line therapy. Oftentimes you have to do combination of non-dihydropyridine and dihydropyridine calcium channel blockers. And if those aren't working, then long-acting nitrates are kind of added in on top of that. The baseline is everyone should be on a statin and have sublingual nitro to kind of have that quick relief. And then you should always be looking at avoidance of triggers. So like some of the medications that we mentioned earlier in this talk, such as triptan therapies. So recently, I think I'd be remiss if I didn't bring up this EDIT CMD trial that just came out, looking at the efficacy, or trying to look at the efficacy of diltiazem to improve vasomotor dysfunction in this patient population. So it basically put patients into two arms, placebo. So this was a randomized controlled trial, multi-center, and it randomized patients with non-obstructive coronary artery disease and angina to placebo versus diltiazem with provocation testing. And it looked at to see if there was any improvement in quality of life or in the function of the vasculature. And their overall study was that it wasn't, but it probably wasn't the right patient population that they were looking at for this. So if you look at, the change in these events, so the epicardial spasms, those patients who were started on diltiazem, so the top is placebo, the bottom is the patients that were in the study arm, and 47% rather had no longer had epicardial spasms after having or being started on diltiazem. And so that's probably the patient population that is going to benefit from diltiazem, and less of the microvascular spasms or no spasms. So 50% of the people didn't even have epicardial spasm. And again, diltiazem is probably working best on that population. And so that's probably the reason for this negative study of effectiveness of diltiazem in this population. So epicardial disease, absolutely. Other diseases may be less consistent with a benefit. So just coming back to the case, so this patient did not have a PCI, and they were diagnosed with vasoreactive angina, again, from having sensitive coronary arteries to the wire. No provocation testing was done because you already had a diagnosis at that point in time. So he was sent home on GDMT, and specifically, amlodipine was added to his regimen to help with his anti-anginal and vasospastic events. But again, he remains high risk without lifestyle modifications, given all the substance that he unfortunately struggles with. So these are some unique discussion points that we can come back to after I finish a couple more slides. But basically, this patient had several risk factors, which we know about, several of which potentially reversible if they get into the right providers to kind of help work through those issues. His specific risk factors resulted in possible rapid progression of atherosclerotic disease. It was interesting that in May, his coronary CTA was basically normal, and then about a year later, it showed all this atherosclerosis. So cocaine is an atherosclerotic medication, or pro-atherosclerotic medication. And but the rapidity of that is a little unusual. So it's possible that maybe the first coronary CTA didn't pick it up, but nonetheless, just kind of an interesting point. And then a little bit of kind of his heart failure. So this patient was unique in the sense that he had pretty severe systolic dysfunction. Again, remember, he had an EF of 15%. And usually we don't start calcium channel blockers on this patient population. But for him, and his blood pressure was actually quite elevated. So he had a lot of systemic vascular resistance. So it's possible that he had lots of like systemic vasospastic disease. And so after being started on a calcium channel blocker, he may notice a lot of improvement in his symptoms. But yeah, there is a risk that, can make his heart failure worse. So, but this patient did tolerate it on follow-up. Given the non-obstructive coronary plaques can be a nidus, and this is just kind of a general discussion point, they can be a nidus for further vasomotor dysfunction. Is there a benefit for stenting these lesions? There hasn't really been any studies that kind of have evaluated this. So it's just kind of proposed that as, if we did stent these lesions, is it possible that they would have less, is it possible they have less vasomotor events there? Maybe not, probably not. But if they already have that much stenosis and you have a little bit of spasm, if you have that same little bit of spasm with a more open artery because of a stent, would these patients have less symptoms? Maybe. Given the safety profile of provocation testing, it should probably be employed more frequently than currently practiced. But the exact population for which this should be employed is kind of gray. Some of the studies will suggest that everyone of non-obstructive coronary artery disease and angina should maybe proceed into getting this testing. But I think we should be a little bit more select in that patient population. And then there's the patients who, you maybe just trial on medical therapy and don't do provocation testing. So it just depends on the severity of their disease. Did they potentially have a syncopal event? Did they have MINOCA? Did they have myocardial infarction? Then maybe having a specific diagnosis in those cases will be much more important. And then some would argue that the epicardial coronary narrowing seen at these concentrations, and I kind of talked about that kind of dose-dependent manner of acetylcholine and how it can cause vasoconstriction physiologically, but that's not the dosing that we're using for this test. Okay, so I'll kind of leave you all with this good quote from Dr. Scott Kinlay, who wrote in, and not to me specifically, but a paper I found of his. And he said, the need for routine provocation testing is uncertain, as it is unlikely to change the clinical practice in most patients with coronary artery disease. Its value probably lies in a small group of patients with non-obstructive disease and recalcitrant symptoms or unexplained sudden cardiac death. Coronary spasm in the former may lead to more intensive vasodilator therapy, in the latter, an implantable cardioverter defibrillator, ICD. These are my resources, several, and thank you to all the people who helped me. And I would be a poor father and remiss if I didn't publicize my adorable family. So thank you.
Very good. Thank you, Matthew. So, yeah, I mean, these I guess, sort of more a comment. I mean, it's an excellent review, and thank you that, these cases, when you're on the inpatient service, these cases of chest pain with mild troponin elevation are very common, and they frequently pose, in a lot of ways, they're sort of the more difficult cases to take care of, because you're sometimes stumped at how deep you want to go in terms of diagnostic testing for patients, whether it's looking for coronary vasospasm or looking for a mild case of myocarditis, or ruling out PE, things of this nature. These, things when we're fairly sure this isn't sort of run-of-the-mill obstructive coronary disease, and we think there's something else going on, one of these other sort of syndromes that can lead to these, and that I'd like to quote at the end, like when do you sort of pursue that additional testing once you've ruled out myocarditis or PE or things of that nature, and you suspect this coronary vasospasm versus just treating versus, pursuing additional workup? Yeah, do you wait on those patients that maybe have already failed first line medical therapy, or like you said, have had like a very dramatic presentation, i.e., arrest or marked troponin elevation? I don't know. I guess I just want you to expand a little bit on sort of that dilemma of and your thoughts on choosing the right patients for further. I'm not sure coronary physiology evaluation is, the right play for every patient you suspect coronary vasospasm, but maybe I'm misguided.
Yeah, and I think it's still really gray. And I think as more studies come out in the future, and we as a group believe in these studies more, we may find a better or best population to study these in. I think the obvious times, there's kind of like Dr. Kinlay was getting at, are these, patients that are high risk. And if we don't do like an intervention or have a specific diagnosis, then it's kind of scares us as the provider, and it's kind of scary for the patient. And so those, I think, absolutely. The middle patient population that's just coming in with angina, with non-obstructive coronary artery disease, I think is challenging. Sometimes it can be for peace of mind for the patients to have a specific diagnosis. So it may be some utility in that. But, just starting patients on anti-anginal therapy is a very reasonable route. So yeah, I think it's still gray, but maybe the patient population with less significant concerns, just starting medical therapy first and kind of seeing how they do.
Good
Stan
morning.
Sherman.
Oh, sorry.
Go ahead, Stan Sherman. I'd just say that, for those of us who follow patients, and those who continue to have, chest discomforts despite good guideline medical therapy, having these tests done, Dr. Toliva has been specializing in this a lot, is very helpful in terms of guiding your medical therapy in the future. And, some of these patients, of course, do get better with ranolazine too. But I'm just saying that for those who continue to have symptoms, this is something that we really need to be doing because it really helps them later on when we decide what therapies. Now, this particular patient has a lot of drug problems, and that's another story. But I mean, for those who don't, it's very helpful.
Yeah, no, thank you for saying that. And two, like, not often are patients on 2 calcium channel blockers. And if you had this specific diagnosis, you'd be much more comfortable probably starting that therapy for them.
Hey, Robbie.
Yes.
Say a word about Prince Metal's angina. If you read all those original works for him, he was watching people in the coronary care units, and I guess people in the clinic too, who had chest discomfort and SC segment elevation with the discomfort, which is a disturbing kind of thing. I think his group of patients were a mixed bag. Some of them obviously were patients who had fixed coronary lesions with spasm or thrombosis on top of them, and others were patients who didn't have obvious coronary atherosclerosis who had spasm. So we use that term loosely, but your presentation today was great in that it kind of expanded on what Dr. Prince Metal talked about early on, but didn't have all the information. So thanks for filling in the blanks.
Oh, thank you.
And this is a difficult group of patients, and they require a lot of things, including nitroglycerin patches and Cialis. So thanks again.
Thank you.
Good morning. This is Olga Televa. I just wanted to congratulate you on the good review and excellent presentation, and also just to mention that I think the value of functional testing is increasing, especially in Minoca patients, because as even the case you presented, this is not his first presentation. This was his second coronary CTA that was done, and then an angiogram. So you could see that these type of patients that keep coming back with recurrent chest pains are a significant burden on the system, and get multiple tests, including non-invasive tests, without a clear diagnosis or answer, or being misdiagnosed as a GI symptoms or anxiety. So finding the right diagnosis is actually very important. And not only that, but just blindly treating them, sometimes they cannot tolerate the medications we're putting them on. So knowing exactly what we're targeting helps with their quality of life. So I think we need to be a bit more open-minded about it, and especially in people that you are thinking of sending for catheterization and you have high suspicion for this type of problem, maybe requesting functional testing up front will save a lot of hassle in the future.
Thank you, Dr. Taleva, and thank you for your input with this case as well.
The preceding program is copyrighted by Emory University.